Hepiniz hoş geldiniz tekrardan. Kongrenin birinci günü.
Welcome again. This is during the first day of the Congress. I am the last speaker after breakfast, and I'm sure that you are by now distracted and you don't have so many questions to ask me, so I consider myself to be lucky because it's stressful to make a speech anyway. So far we've talked about PTSD, on the axis of the PTSD, but I'd like to take a step sideways. But before that, I'd like to ask you a question. Has any one of you diagnosed traumatic brain damage or mild traumatic brain injury and not PTSD to the patient who primarily came to them? Because that's what I'm going to be talking about. Okay, nobody. There are some cases that teach the physician, and the reason why I am so much interested in this one, traumatic brain injury, is 3 of my patients. I thought that they were PTSD. 2 of them also had traumatic brain injury as comorbidities. These 3 cases. When I probed deeper, I realized that I had only seen the tip of the iceberg, and that's why I wanted to talk to you today about the dark side of the PTSD. If you're dealing with psychiatry, especially focusing on trauma, this is a very ordinary story you come across. There has been an accident, a traffic accident. There's a woman who underwent a life threat and is now suffering the trauma of it. This is what we're dealing with. And the metaphor here is that I believe that this woman in the picture represents the soul and the spirit of what we call a human. And the body is the body, like the body of a car. When you look at her face, you see some bruises. She has undergone a catastrophic event and she is now going through the effects of that. We don't know whether she will be held accountable for this traffic accident or what happened to the car. We don't know whether she even cares, but she's terribly affected. And it's because of our profession, because psychiatry and neurology are separated, we think that way. I mean, we don't see the car, we see the woman. That represents the human soul. That's where we are stuck in. But is there a relationship, or is there an interaction between the car and the woman in the picture? Before saying goodbye to psychiatry, I'd like to talk a little bit about the 12 steps of PTSD. This is Hartman's 12 steps of PTSD model, and I think it's very helpful. This woman is undergoing acute anxiety, and that's why she also has depressive symptoms, and then the rest she will try to shame others, or she's trying to be filled with shame and then feel guilty, then she will with anger or fear, PTSD comes up, and then this anxiety will become more generalized, and she will be focusing on self-worth dissipating, feeling worthless. She will feel shame and guilt, and she will refrain from human contact, and then she will become confused. Can she really trust? Can one event really change her life? Can she remember the whole of the event? Does she really remember it all? And can she trust her memory? And then there will be pain. This emotional or spiritual pain, as much as studies reveal physical pain, somatic, real, severe pain that distorts her quality of life. And finally, she will have relapses with activating events. This is the panorama of PTSD, but that's not what I'm going to talk about. I'll be focusing on the body. What happens to the car? What happens to the cars in this picture? What happens to the human body? For us, there's a division of labor. Psychiatry takes the human spirit, the human soul, and otherwise we have orthopedics, neurosurgery, neurology, imaging techniques, radiology, and other relevant branches. But we're not involved here. We're involved in the human. But what happens in the body? Now, when you look at the central nervous system, there could be broken bones, there could be spinal cord injuries, ligaments, there could be lacerations, cuts, bruises, there could be brain damage, there can be soft tissue damage, herniated discs, hemorrhage. You can feel yourselves now attending a neurosurgery rotation. We don't, of course, look at contusions. They're not, it seems, they're not related with psychiatry. Neurologists or neurosurgeons work very well because they see this present before their eyes, and they can diagnose very well with imaging techniques or other techniques. There's no way that they can miss this sort of a patient, and we feel relaxed at their hands. Something more dramatic. I don't think any surgeon misses that when there's penetration. And you know that across these penetrations, those which are more deadly are the fire gun penetrations, and unfortunately patients also know this, so when they are suicidal, 99% of the time they're able to kill themselves if they do a gunshot wound. Okay, something closer to neurology is another type of brain trauma, which is diffuse axonal injury. Sometimes neurologists miss this, sometimes they don't. And the mechanism is quite different, actually, because the impact to the brain or the head is not penetrating, but the head is shaking. Imagine, for instance, there's a car crash, and imagine the dummy sitting in that car, and what happens to the head of the dummy. So that's sort of a shaking. And this huge torque that occurs causes injury, causing torsions and breaks in the neuron, which is called shearing. Which part of the body is mobile on shaking, and which part is not mobile, is not movable? Well, the brain stem has the narrowest channel, so it remains stable, but the cortex, relative to this, is more mobile, more active. So here I'm talking about an injury, and here we see the MRI of that, and depending on the severity, there could be confusion, coma, or death. Thankfully, our neurologists and our neurosurgeons don't miss that type of cases either. I've already talked about contusion, penetration, and diffuse axonal injury. So wherever it affects in the central nervous system, findings come up. And there is also concussion, a brain concussion. What happens in concussions? This happens mainly in athletes in the United States. There is no penetrating trauma that doesn't cause direct tissue injury, but there is a device, there's something that hits the head that doesn't penetrate to the head, or that could be a fall from the stairs, or that could be a penetrating, or the secondary effects of a penetrating wound, and there's a concussion. Neurosurgeons and neurologists don't really care too much about this because it's called concussion. It would go away, basic. And the brain goes up and down, hits the walls, and if there's an MRI, if there's a finding on the MRI, they react accordingly. If there's a neurological deficit, they act accordingly, and then there'll be a solution. But if there's no positive finding and no change of consciousness, the 75% of the ED visits by these sorts of patients are concussions, and most of the cases, concussions recover on their own. And most of these patients have to undergo psychiatry clinics because of the trauma they had undergone. Like I say, we're related with the woman in the picture, we're not related with the car in the picture, and we start listening to their problems. This is now more valid for the military population, and it's very confusing. It took me quite a while to understand how that happens. There's a blast, and here there's a four-dimensional injury, blast wave especially. The skull is physically not impacted. There is no shrapnel, or there is no piece of anything that hits the brain, but the skull gets the impact of this blast wave. It's a wave, and there could, as a result, be concussions. Actually, over the past 5 or 10 years, we've come to understand this fact. So concussions are especially important because they make up of 75% of brain traumas. What happens then in the anatomy, or what's the pathology of it? First of all, it is not yet discovered that the cause is the trauma or the shaking, but the brain blood flow is interrupted. This red line is where the blood flow is reduced, and the glutamate stores are then depleted. That causes an excessive amount of calcium coming in and efflux of potassium. And this calcium disrupts the metabolism, and the neuron already has scarce resources to produce energies, and because of the calcium inflow, this energy is lowered, and the potassium that's released damages the capillary blood flows, constricts the capillary blood capillaries, distorts the blood flow there, and there's an energy crisis that occurs. So what we call a concussion, what we say, it's just a concussion, it will go away. This is what happens to the brain. This energy crisis, if it's not acute, if it's subacute or chronic, in that case these are called persistent brain injury patients. But for neurologists, no MR findings, no neurological findings in the examinations, these patients may be missed very easily. How about the symptoms of concussion? This, by the way, concussion is an anatomical descriptor. I mean, it's a term used by the neurosurgeons. And these are the main symptoms that do not give us any localized findings. There could be headache, nausea, vomiting, stability problems, balance problems, tremor, tingling, sensitive to light or noise, visual problems, dizziness, or dazed or stunned. If the patient has concussion or mild TBI, which is mild traumatic brain injury, if you're suspicious of a TBI and cannot explain it with PTSD, you must question these physical symptoms because they are guiding. If during the event there has been a loss of consciousness or unresponsiveness for half an hour, it could be possibly a missed TBI case. How about cognitive symptoms? How about emotional or sleep symptoms? It's just like the woman in the picture, no? Actually, no. Because in TBI, these symptoms occur without PTSD. They can be comorbidities, but they may also not be comorbidities. This is a very sophisticated, a very complicated picture. I'm not going to talk about this. The neurologists don't miss that. That's what I'm talking about. Actually, this is at the heart of this talk. So there's a very brief loss of consciousness, about less than 30 seconds or so. This may not happen. There could only be, the person may be dazed or confused. Testing or scans of the brain may appear normal. And this is explained by what we call a concussion. Okay, let's give some facts. 1.7 million TBIs occur every year in the US. 75% of them are concussions, and 35% due to falls. And here we see how the PTSD and TBI symptoms overlap. TBI also has a dimension that's outside the scope of PTSD, but there are some overlaps where the woman is injured and the car is damaged. So this is what you see in the middle where they overlap. But there is also PTSD with no TBI. And this should not be missed in differential diagnosis. So, what happens? What happened to me, or what happened to our clinic? Neurological sciences say the patient has nothing. This patient is somatizing, simulating, or conversive. They send the patient to us, and then, if we're uninformed, then there could be delayed treatment or untreatment. We don't know whether it's TS or PTSD. We say that there are some PTSD symptoms, but the patient is exaggerating, probably, we say. Finally, We also need to talk about high rates of suicidality. There are many other long-term implications. Now, how about the car and the woman? Is there a relationship? Yes, there is. If somebody gets out of this accident without any harm, there's a 9% chance of developing PTSD. Sorry, this is a military field study, I have to say. If no injury, then 9% chance for PTSD. If there is injury, physical injury like fractures, 16% chance for PTSD. But if there's also TBI, then the PTSD rates go up to 44%. What does that mean? Again, this is a study, and in the past, when somebody got injured and lost consciousness, we would say that PTSD would not develop because the patient is unconscious anyway. How can you develop PTSD without being conscious? But that's wrong, because when the executive function is destroyed, then yes, you still can show PTSD. So this damage in the car does have an impact on the psychology of the patient as well. So TBI increases 2.8 times PTSD and depression. It's like a catalyst. So TBI, yes, does also fall under our scope as psychiatrists. If you are suspicious, then please take a look at all the images, all imaging techniques, all electrophysiological methods. We were able to catch these cases with PET scans. Süleyman talked about how the male and female brain responds to PTSD, and I think the reason is the brains are organized differently. So here's my answer to Süleyman.